So always plan for a backup if all else fails. Okay. So we'll do this as a group. It actually may go faster. Okay, question one. Let me give you about a minute or so to think about this. Let me just stop there. My timer on my cell phone is not working either. I think I'm having an electronic moment here or something. But let's just kind of go over this here. Let's just kind of go down this real fast. Cholesterol is converted to pregnenolone by STAR, STAR. And just anyone, do you think that's true or false?
Also,
False.
False. Okay, yeah. Well, what exactly does STAR do?
it brings it across the mitochondrial membrane.
Okay, that's good. It brings it into the mitochondria,
Yeah.
not out of. Okay. B is cholesterol is converted to pregnenolone by cholesterol desmolase. Well, that sounds pretty good, huh? Everyone's saying, yeah, that sounds pretty good. Cholesterol esters are converted to cholesterol by hydrolysis. So we're probably talking about these storage vacuoles where they're stored as esters and then they're broken down. So the cholesterol again. Peptide prohormones are cleaved to become active hormones with calcium ions. Well, that really does happen, but we're not talking about peptide hormones. And then peptide hormones are active forms or deactive. Again, we're not talking about peptide hormones because they're not involved. Their synthesis does not involve mitochondria. Okay, any questions about this? I think we've had similar questions, but they're all asked in slightly different ways. Okay, so that's the answer there. Good. Okay, so let me give you at least a minute to think about this. Okay, the first one, thyroxine is derived from an amine, which is true, and it is thus hydrophilic. And most amines are hydrophilic, but again, thyroxine is the exception to that rule. Number two, thyroxine is derived from cholesterol. That's false. So it's a steroid. Cholesterol is a steroid. That's true. But the first statement is incorrect. So that's false. It is derived from an amine. That's true. But it's hydrophobic. And everyone's saying, yeah, okay, good. So we'll go with C. And we just won't stop there. Let's just kind of go through the whole shebang here. It is derived from cholesterol. That's wrong. So it's receptors in the cell membrane. That statement is wrong also. So it's a double wrong. It is derived from neither amine or cholesterol. And that's wrong because we just said it's from amine. So, okay. And so again, that goes back to the one chart that shows how L-tyrosine through a series of steps can become norepinephrine, epinephrine, and further up the chain, L-tyrosine, there's a branch coming off, it can become thyroxine. And thyroxine is sort of the exception to all these different rules that we have.
Dr. Honda,
Yeah.
my internet kind of timed out. Can I see number 1 just briefly?
Geez. How's that?
Okay. Thank you.
It's basically the question about the mitochondria and how are steroids formed in mitochondria. Well, what are the sequence of steps? Okay, so 3. This one, I'll give you about a minute to think about this. Okay. Again, we've had the same question in different variations. The G protein coupled receptors, GPCR, and are present only in nuclear receptors. Well, that's false, right? Because we know they're membrane receptors. Are found on cell membranes. Okay, that's good. For hydrophobic hormones, we know something's wrong there. Hydrophobic, we know they go to the nuclear receptors. Have different subunits. That is correct. The G proteins have all these different alpha subunits, which have different outcomes. Well, that sounds pretty reasonable. D have different alpha subunits. That's correct, with identical outcomes. That can be true. Actually, the table that I provided you in the pre-read, I think there are like 2 different subunits, alpha subunits, that do have the same outcome. But generally speaking, each of the subunits has a different outcome. And then finally, the G proteins incorporated JAK-STAT as a secondary pathway. Well, JAK-STAT is just a totally different secondary pathway. It has nothing to do with G protein. So again, the second messengers that are stimulated from the membrane receptors, that's something that the Scholar RX Bricks spends a lot of time talking about. And again, the initial outline did not include this, but I just have a strong suspicion there's something very important about this. I guess if you want to separate, the good students from the really, really good students, you ask a question about the second messenger. So if you're trying to triage where you need to study, I would say, if you want to ace the test, then you got to know this. If you just want to survive and pass the test, then maybe you can kind of come back to this later, just before the test. But again, I have a strong suspicion second messengers are going to show up again and again and again. Okay. Oh, here's this god-awful question. Okay. Let me just kind of read this out loud so we know kind of be on the same frequency here. Negative feedback is an important control mechanism for hypothalamic anterior pituitary target organ excesses. Well, that's true. And I just want to emphasize again, most of the feedback systems are negative feedbacks, a few are positive, and most of the neoplastic, or not neoplastic, pathologic processes have positive feedback. Okay, so we're talking about the basic normal negative feedback. A patient has suffered a severe episode of hypotension, and imaging studies suggest there may be severe damage to the pituitary gland. And again, you have severe hypotension, oxygen's not getting to the pituitary gland, it dies in necrosis. And if this occurs in a certain clinical situation of a woman that's delivering a baby, sometimes they lose a lot of blood during labor and delivery. They have a sudden drop of blood pressure, and some of them will develop necrosis, sometimes just partial necrosis of the pituitary gland. And so the big clinical finding in this syndrome is the mothers can't lactate because we've necrosed part of the pituitary gland and they can't produce prolactin anymore. And so that's called Sheehan syndrome, Sheehan. That's mentioned in the pre-read. And sometimes that could be asked hypothetically in a question in some form. Sheehan syndrome talks about women delivering babies have massive hemorrhage, hypertension, and necrosis of the pituitary gland, which results in all kind of problems afterwards. The biggest problem is they can't lactate. Usually, if there's that much damage to the pituitary gland, there are other pituitary functions that are lost. But the lactational aspect is the most dramatic effect you'd see right away. I shouldn't say right away, within days or weeks. Okay, so anyhow, this person has something wrong with the pituitary gland due to hypertension. How would this impact the negative feedback system? Okay, so we have a damaged pituitary gland. How does that impact the negative feedback system? So there's no change because the negative feedback system is always to the hypothalamus, which in this patient is still intact because we just have damage to the pituitary gland. Does anyone have any comments about that statement? Just shout out. This is a shout out session. I'm sorry. I'm sorry. Can you repeat that for me?
I always kind of hesitate when something says never or always, and okay. I know that some of our negative feedback does go to the pituitary, so that's kind of the issue I have with that one. Okay, so you don't like the term always or never. And in terms of strategy for test taking, when we write questions, I'm told we shouldn't use that because students use that too. That there are only a few things that are always or never. And I think that's a really good observation. That's a good take-home message, because what I'm actually trying to get someone to say is negative feedback can be to either the hypothalamus or it can be to the pituitary gland, anterior pituitary, or it can be both. Okay, so negative feedback does not imply. I'm sorry, Christine, there's something in your field there that I see. Is that something real? Oh, it's a cat. Okay. I just saw this stripe thing. I'm like, my God, what is that? Okay. Okay, so going back to A, negative feedback can go to the anterior pituitary or the hypothalamus, or actually both. Okay. Now, B is no change because the negative feedback system is replaced with nerve signals to initiate inhibition. Who wants to take a stab at that? Does that sound like, could that really happen? Or is that just science fiction?
You can't grow new nerves after you're born, usually. It's unlikely.
Okay. Are there any nerves that really go to the anterior pituitary and tell it to do things?
No.
I'm sort of like, I can't think of one off the hand. But having said that, there may be one somewhere that I'm not aware of. I mean, there are some nerves up there, but to the best of our knowledge, that's not a control mechanism. Now, there are nerves that go to the hypothalamus. That's very clear. Okay, so probably B is probably not correct. D is no change because the anterior pituitary is severely damaged. Okay, that's a given. But the function of the trope, the cells that produce individual hormones, is now replaced by hypothalamic nuclei, which is still under negative feedback control. So I think the big question here is there a situation where the hypothalamic nuclei take over the function of the trope in the anterior pituitary? How's that for science fiction kind of stuff.
No, I don't think the cell bodies can generate new hormones.
Okay, I think to the best of my knowledge, I believe the statement, well, the no change is incorrect, but the rest of the statement, is probably science fiction. Now we know in the posterior pituitary that the hormones that are secreted come from the hypothalamus, but for the anterior pituitary, the hormones that the anterior pituitary secrete comes only from the anterior pituitary. Okay, so now we're left with D. Okay, we've kind of went through A, B, C. They don't sound very good, D. Does D make sense? The negative feedback system no longer works in the anterior pituitary because the tropes are non-functional or dead because they had an episode of severe hypotension. The tropes can, actually it says no, it should be no longer receive stimuli or produce products because dead things can't react anymore. They can't produce anymore. So I think that statement is basically true. It's written in kind of a funky way. And actually having dead cells says that it doesn't make any sense to have negative feedback because you can't have a feedback system to something that's no longer functional. So I'd be the first to say that this is a pretty funky question, but it does ask some hypothetical thought questions. Any comments about this? Believe me, you'll not see a question like this on the exam. It is too obtuse. Okay, 52. Let me give you a couple minutes to think about this. Just a minute, and then we'll get back.
I'm sorry, Dr. Honda. What was
Yeah.
the answer for number 4 again?
I'm sorry?
What was the answer for number 4 again?
I believe it was D, the last one.
Awesome. Thank you so much.
Yeah. Okay, let's just kind of run through this systematically again. Okay, so we have kind of a middle-aged woman with a head injury, that keeps on popping up again in questions: head injuries, car accidents, head trauma. Comes emergency room, has thirst, really bad thirst, increased urine production, polyuria, and she's hypotensive and tachycardic. And the urine analysis shows the urine has low specific gravity. It's very watery. So pretty much we can zero in immediately about some hormone that involves the kidney, okay? Thyroxine, we think of generally affecting all kind of cells, general metabolism, not specific for the kidney. Growth hormone, again, we think of something affecting a large number of cells, but again, we don't think of growth hormone affecting kidney. ADH, antidiuretic hormone, yeah, that's number one candidate. Let's say we don't even know what ADH does, but it has the word diuretic, and we're talking about urine. So, gee, that sort of fits. Oxytocin, that has to do with pushing milk out of the ducts and lactating breast. And this doesn't sound like anything about nursing babies. And prolactin, again, that has to do with milk production. And even though we are dealing with a female, she doesn't say anything about having galactorrhea or excess production of milk. So just by a matter of elimination is ADH. But perhaps the important thing to take home is all these different symptoms. You should be able to see these symptoms And remember this diagram that's in the pre-read, and I think it was mentioned in one of the applications already. It's good to kind of remember all these different syndromes. These are all things that happen when you do not have ADH. You don't have ADH, you're just drinking water like crazy. So let's kind of look at this question one more time. Why doesn't this patient have ADH? Just anyone. Why doesn't this patient have ADH?
Damage to the posterior pituitary or the infundibulum.
Yeah, damage to the pituitary stalk or the infundibulum. The hypothalamus, is probably still making ADH, but because there's damage to the stalk, the bulk of the ADH is not getting to the body where it's supposed to be. Okay, and then you have all these signs and symptoms because the kidneys aren't getting the right message, and they're just producing this lots of dilute urine. Okay, and I think I forgot who it was. Someone had mentioned that soldiers that get head trauma, you kind of look out for stuff like this. Again, this points to probably a transection of the pituitary stalk. This is another set of symptoms that could occur. Okay, number 6. Let's take a minute or so to look at this. Okay, let's kind of start just by quickly looking at the possible answers. Okay, well, we know that the chief complaint here is leaking breast or galactorrhea. She's producing milk, probably when she's not supposed to, because the pregnancy test says she's negative, and we're assuming she should not have the hormones running around to have high prolactin levels. Okay, so we're talking about the breast. The breasts are in overdrive here. And so just what do we know about prolactin? We can say prolactin, I think that causes production of breast milk. So you're looking for something that has increased prolactin levels. So we can probably, when we see decreased prolactin levels, just cross that off, saying, okay, don't even worry about all this other stuff here. Let's just cross that out. Oxytocin has to do with the breast too, but what does oxytocin do for lactating breast?
Ejection.
I'm sorry?
It's involved in the ejection of the milk.
That's right. It causes the mild epithelial cells surrounding the milk ducts to contract. They contract and they force the milk out. So again, we know this woman is not pregnant. And is this really, I guess you could ask yourself, is this a question of milk ejection or milk production?
Production.
Probably production, ejection. That's a good thought to keep in the back of your mind. Could this be a trick question here? Okay, because it has to do with milk. And okay, now we go back and look at saying, okay, wait, she was in a car accident, blah, blah, blah. She's got headaches. So we're thinking they're trying to tell us something's wrong with the pituitary. And, again, let's just say hypothetically, the pituitary stalk is transected. And oxytocin comes from where again? Where's oxytocin?
Posterior pituitary.
Pituitary.
It's released from the posterior pituitary.
Oh, hypothalamus.
hypothalamus. And who can remember which nuclei?
Paraventricular.
Paraventricular.
Thank you, paraventricular, yes. In fact, if I remember, I got that mixed up and there's a little note in Brightspace. It has to do one of the slides that had mixed it up. Okay, so there are all these nuclei in the hypothalamus. Those are two that you probably want to keep in mind. They're reasonable test questions. This the paraventricular and the supraoptic. Okay, so we're thinking still D and E, because we're thinking of increased prolactin. Now we're dealing with this dopamine business. So is it high dopamine or low dopamine that stimulates prolactin production?
Low dopamine.
Low dopamine, okay. And how would you explain that to someone? What's the term we're looking for?
Dopamine inhibits
That's
its
right.
production.
Okay, that's right. Dopamine. This is one of those few cases where the hypothalamus is making an inhibitor, and it's the main function of the hypothalamus in regards to prolactin. It's the brake. It's stepping on the brake. The anterior pituitary always wants to be secreting prolactin, but the hypothalamus steps in and says, no, you will not make prolactin, not until I tell you to. Okay, so this poor individual has leaking breasts, so she has increased prolactin because she has low dopamine. We're not stepping on the brake. So, okay, so this goes back to this feedback mechanism here. So it's interesting, prolactin is one of those positive feedback mechanisms. This is one of those exceptions. And the hypothalamus produces two substances, dopamine, and this is the main pathway here. It wants to produce dopamine to stop the production of prolactin. Dopamine is a neurotransmitter. It's used throughout the brain, but for some reason, this has become the main function here. Yes, Ricky, you've got a question.
Yeah, sorry. Could you end up with, if you had a drastic and sudden drop in dopamine, could you, because of that positive feedback, end up producing more prolactin?
Yes, you can. In fact, I think I mentioned in the pre-read, there are certain drugs that inhibit dopamine. And one of the side effects of some of these, I think they're the antipsychotic drugs, if I remember correctly. If you take too much of some of these certain drugs, one of the side effects is galactorrhea, because it's interfering with dopamine, and now prolactin is being made. You can go back over the notes and you'll see that one of the slides. Okay, now the other thing is TRH is out here too, thyroid releasing hormone. Why this is so, I do not know. But thyroid releasing hormone not only goes to the thyrotropes and is involved in thyroxine production, but I should say TSH production from the anterior pituitary, but it's also involving the leptotropes here. So TRH, thyrotropin releasing hormone, can stimulate prolactin production. So, there is that interface between the thyroid disorders and prolactin. And I think I mentioned that we sometimes see this in patients who are hypothyroid. Patients who are hypothyroid sometimes have increased prolactin levels. And that's because over here, when you are hypothyroid, your hypothalamus is sensing that you don't have enough T3 and T4. So it starts sending signals to the thyrotropin releasing hormone. It says, make more, make more, make more. But while it's doing that, it's also stimulating the leptotropes to make more prolactin. Now, this doesn't happen in all patients that are hypothyroid, but some of them have this effect. And so supposedly it's reported in some patients with hypothyroidism. Any questions about that? Okay. So here we go. Increased prolactin levels with low dopamine levels. Okay. Any questions about this? We just tortured this endlessly.
Yeah, Dr. Honda.
Yeah.
So how can we definitively eliminate that it might be oxytocin?
I think the only argument I could make off the top of my head is because it's really milk production. That's what the problem is, galactorrhea. There's too much milk, whether it's squirted out or not. I mean, you could have too much oxytocin, but you got to have milk to squirt out. You're not going to have milk to squirt out unless there's prolactin. That's the only thing I could argue.
Dr. Honda,
Yeah.
with oxytocin, oxytocin, I believe, induces labor as well, right? So could possibly be an issue with oxytocin. Could it be like uterine cramping as well?
If you have
like if we're saying that if oxytocin was the problem, I think there would be more happening to her than just the increased of of these leaking breasts that her.
Right. I would say that's a possibility, but clinically, I don't know if that happens. I think there's something more complex going on with oxytocin and the smooth muscles of the uterus. I think there's modification of the effect of oxytocin by estrogen and progesterone on the smooth muscle cells. So I mean, there's more going on, but I think that's a good thought to keep in mind. We know that oxytocin does also affect the uterus. It helps with the contractions during labor. So I'm just kind of saying yes, but may not be clinically seen.
Dr. Honda, can I ask one last question? I'll be quick. Is there a chance that clinically we could see the dopamine spike because our system recognizes that the prolactin's out of hand and it's from a cause other than a lack of dopamine, and so our dopamine spikes to shut it down? Or since dopamine's the majority regulator here, we would have to see low dopamine to see the high prolactin?
I'm not sure if I follow that.
Okay.
Okay.
It's okay. I'll just think on it.
You'll think about it. Okay.
Yeah, it's okay.
Okay. So the one, I'm always learning new things. So something I learned last night was my brain doesn't function after 9 o'clock, but well, at least not in terms of endocrinology. One of your classmates emailed me. I happened to be working at 9 o'clock. I got this email message, and I just totally misunderstood the question. I was thinking about something else, and I wrote back a reply, and she was very gracious about it. She emailed me back later saying, but sort of like, I didn't ask you that. So my new rule for myself is if I get an email after 9 o'clock, I'm not going to answer until the next day when I had a good night's rest. So. Okay, but please, if you do have questions, send me emails. I will get to them as quickly as possible. But if I get them after 9, I'm going to let them wait till the next day. Okay, here's kind of a long question. I'll give you at least a minute to look at this. Okay, I'm going to push people on time here. The first question would be just from the clinical description of this 40-year-old actor, what condition are we talking about?
Acromegaly.
Acromegaly. Okay, good. So, and it has to do with growth hormone in some way. So, once we figured out we're talking about acromegaly, the question is, how do we test for that? And we had a similar question before, and we mentioned that growth hormones has a diurnal. It peaks at nighttime when we're asleep and then drops very low throughout the rest of the day. It's pulsatile, in other words, the gland is excreting it, pulses, and sometimes it'll just stop altogether. And the take-home message was one measurement of growth hormone may be very misleading. And I think I also tried to throw in a footnote, I didn't make clear, is that there's something about the pulses that is signaling the cells what to do. It's not just the simple level, the high level of growth hormone, it's the pulsatile message. So hypothetically, it is possible we have, a low level of growth hormone, and because it's pulsating at a certain rate, the cells kick in. So, and we just don't understand that right now. But anyhow, I think we had also talked about the answer. Someone just shout out what the answer is. Don't be afraid. Just shout it out. Be brave. B. Okay, good. Because growth hormone, if you just take one sample, probably normal, might be slightly elevated, who knows. But we know growth hormone targets the liver. Liver starts producing insulin growth factor 1, and it does that at a fairly stable rate. And we know that there's a tight link between growth hormone and IGF-1. So if a person has something elevating growth hormone, either the absolute level or the pulsatile nature, IGF-1 is going to be elevated, and that's more constant. So that's something that you want to measure. And so someone with acromegaly would have normal growth hormones and elevated IGF-1. Okay, that's all we're trying to get here. Now, since we're talking about distractors here, I think in your DSA, there is a section about ghrelins, right? Ghrelins here. What does ghrelin do? Anyone?
Growth hormone releasing factor.
Okay, yes, it's involved with growth hormones, but what does ghrelin itself do? What's the big thing that we know it does?
Increases hunger.
That's right. Supposedly, when your stomach is growling because your ghrelin levels are high. It has to do with hunger. And so I think I had a little ditty in there about, gastric bypass surgery. There's a lot of interest in when you remove part of someone's stomach, their ghrelin levels go down. And people are always wondering, are people losing weight from gastric bypass surgery because of ghrelin? And, there is some evidence that suggests when you remove part of someone's stomach, their ghrelin levels go down. And that's what's really driving them to lose weight, is that they're not hungry anymore. That I'm not entirely sure. We have several surgeons in town that specialize in this. And I think Dr. Higa he's actually like the president of the Gastric Bypass National Society or something like that. And he's always studying this, and I think he mentioned to me once that now all the research on ghrelin is very confused. So I think that's something that will get sorted out eventually. Okay, yeah. Any questions? Okay. IGF-1 growth hormones. Acromegaly. Oh, and this is sort of fun. If you ever go to the internet, type in acromegaly, there are all these pictures of before and after. And, again, just to highlight these changes that, again, develop very slowly over time. And, we see what they call the coarsening of the face. The chin gets big, the lips are big. Here's, fairly nice looking mature woman, and her face is just changing very slowly. This picture here shows that you get really big hands. I have that up here. This woman has this really long face now. Like that. So acromegaly. And
Is there a
remember, I told you the
reason-
story about the neurosurgeon at Johns Hopkins. You know, so probably he took this this neurosurgeon who just came into town, and he probably saw someone that kind of looked like this. And
Oh yeah, you told us that.
yeah, and so this is probably what he saw. The person says, "This person's got acromegaly." You know, you can recognize it. But if you had seen it develop over 10 years' time, you may be just totally oblivious to it.
They all seem to their faces seem to shift in the same direction as well.
Yeah, yeah,
Is that a feature?
yeah. Yeah, the chin gets longer, the cheeks get wider, lips get bigger.
Sort of down to the left.
Yeah. Okay.
If you don't need Botox, you could just.
Okay.
I'm
So-
sorry, I just popped to ask, are you guys okay?
I'm sorry?
Are you okay?
No, I'm fine.
You come help us. It's so bad. No,
I'm torturing these students with the whip
I
and
mean,
stuff.
some texted me that you may have some Zoom problems.
Well, I did, but I can talk to you later. But I think, you know, I had a secondary pathway here to recover from. So,
All right.
okay. Okay, so there is no question 8. Question 8 disappeared. 9. Now, I'll be quite honest. I stole this question. I found the source of some quote board type questions, and I just lifted this. So if you've come across this, you recognize it. I didn't write this. I just kind of lifted this. So I'll give you a minute to read this. Okay. Does anyone want to just take a stab at what they think the right answer is? Go ahead, just shout it out.
I am thinking hyperthyroidism.
Okay.
Thinking you
And-
might.
And,
Sorry.
and why would you say that? What's
I'm thinking because tyrosine is used to produce T3 and T4. If you're already making too much of it, it might be bad to load more in, but I'm not totally sure. I'm open to other things.
okay? Again, I lifted this question from a different source, but they claim that indeed these pills with L-tyrosine can increase the level of thyroxine in individuals. And of course, if you're already hyperthyroid, this is probably not a good thing to have on board. Hypothyroidism, I kind of wonder if that might be a good thing to have. I'm not really sure if you're hypothyroid, but taking L-tyrosine help, I'd have to think about that. To the best of our knowledge, L-tyrosine is not involved in the synthesis of prolactin in a prolactin secreting tumor or in ADH, which would involve diabetes insipidus. Okay, so that's one of those, what I call the example of the extraneous herb that does something to you. In this case, it's L-tyrosine. Now, this is another one that I took. I kind of modified it a little bit. But I don't take credit for this. So just take a few minutes. Miriam, or is that a live feed or is that something you taped?
The trees?
Yeah,
Oh, it's just the backyard.
it's the backyard.
Yeah.
I'd like to be where you are. That seems so nice.
Thank you. They started blooming last week. It's been really pretty.
Okay. Okay, so let's go through this. We have a new drug being developed in animal studies and has an unusual effect. It increases the level of thyrotropin releasing hormone, or TRH. Now, we're asking, if you give this to a male subject, what possible side effects? In other words, what does TRH increase? TRH should be increasing thyroxine, right? And so you would think the patient or the male subject might become hyperthyroid. And so to sort this through, you have to remember, what are the symptoms of hyperthyroidism? Is it constipation and hair loss? You have to go quick. You got to find that diagram. It shows what all the symptoms are.
I think that constipation, hair loss, and decreased libido were all hypothyroid.
Hypothyroid. Okay, so that's in the mix here. I'm going to skip decreased libido for a minute here. Concentrated urine. What are we talking about there? Probably. The only thing we talked about is probably ADH, right? ADH. So does thyroid releasing hormone have anything to do with ADH? Not to my knowledge. Okay. So the question is decreased libido. Okay.
Can I ask about that?
Yeah.
So in a woman, wouldn't that reduce the amount of increase the amount of estrogen to have more TRH? And so would that happen in a man too? And then would that change out where the testosterone goes?
So you're saying TRH increases estrogen? Is that what I heard?
That's what I was asking. Wasn't it increased?
I don't remember off the top of my head.
Decreased libido.
Ron,
Does anyone else remember? Does TRH increase estrogen?
Ron, I think it had more to do with the fact that this is causing prolactinemia. And that has to do with LH and FSH.
And the estrogen lowers the binding or raises the binding proteins. I think that was it.
Okay.
Okay, I'm glad you sorted that out. But I think this is what the test writer was trying to get at, that TRH, again, going back, that it overlaps with prolactin production. I think someone mentioned prolactin again. So if you have too much TRH, it's going to stimulate the lactotropes to produce prolactin. And one of the side effects of prolactin is hypogonadism, which would result in decreased libido for male. So I believe the intent of this question was decreased libido. Now, is decreased libido a major outcome of hypothyroidism? I'd have to go back and think about it. I mean, it sort of makes sense. If you don't have any energy, well, you're not interested in having sex. So, yeah, but in terms, I think they're trying to get at prolactin here.
Dr. Honda, I have a quick question. So both hyper and hypo, they will result in decreased libido?
For thyroxine?
Yes.
In all honesty, I've got to go back and look at the cartoon myself.
Thank you.
Libido usually is not high on the list of things you want to ask the patient if you're trying to sort out if their thyroid's okay.
Because in your note, you said decreases also may result in loss of libido. That's why.
I see. Okay. So it's mentioned there just to be absolutely thorough. I think this raises an interesting question that I just want to throw out real fast, and it'll come up later during medical school, and that is, do you really want to know about your patient's libido? I mean, if you're just going to meet a patient and talk with them for 10 minutes, is that on your list of things you want to talk to every single patient about?
Yes, please.
Do your patients come to you with all kind of, complaints? And do they want the doctor to ask them about their libido? So, someone's shaking their head. Of course, everyone wants to talk about libido, right? But I remember when I went to medical school, one of my classmates asked the question like, well, if there's something complex about their sexual activity and there's nothing I can do about it, why should I ask unless I can do something for them about it? So I think that's an interesting question to be asking. So, but in terms of, hypothyroidism, it's probably one of the signs and symptoms, but I don't think people, even an endocrinologist, would be asking that right off the bat. Somewhere down the line, it may be interesting to know, but is that really going to help with the diagnosis? For hypo and hyperthyroidism, it's the lab test. Ultimately, it's going to tell you what the diagnosis is. Do you need to know, how often the person's having sex? I would venture to say probably not. Okay, enough of that. Sorry, that took way too much time. Okay, last question. Boy, this is a real nightmare. So let me give you at least 2 minutes to read this, and then we'll come talk about this. Okay, I think everyone has had a chance to run through this first. I'll have to be honest again, this was lifted from another source of board type questions. I've modified it a little bit. And in all honesty, I don't like the answer that I tried to develop here, but I think it's an interesting exercise in trying to reason this out. So basically, we have 4 findings. Okay, we have information from the peripheral blood, and this is findings are telling us about what the pituitary gland is doing. And we have this tortured method of finding blood samples in the anterior pituitary, which probably is giving us information about what the hypothalamus is doing. So we have these 4 clues of what's going on in the hypothalamic pituitary axis. Now, we know the patient has hypothyroidism, so they have a low T4, that's sort of a given. and we know they have galactorrhea. And so we know they have high prolactin. And actually, I didn't think about it when I was writing, working on this question. We had already talked about this. We had talked about how high TRH can stimulate the pituitary to directly secrete prolactin. So the first question we should keep in the back of our minds is this simple TRH acting directly on the lactotropes, on the receptor sites. So now we went to the trouble to get this blood from the anterior pituitary. So this is products coming from the hypothalamus. The TRH is low. Okay. Now, if we have low T4 and we have an intact hypothalamus, would we expect low TRH or high TRH if the hypothalamus is doing what it's supposed to be doing?
It should be high.
Should be high, right? It's detecting levels of T3, T4. It's saying there's low T4, we need more. So I'm trying to send a message of TRH, but here something's wrong. The TRH levels are low. Okay, so now we're looking at the dopamine. Dopamine level is high, and should we expect that? I guess if there's feedback from prolactin back to the hypothalamus, would detect high levels of prolactin and say, wait a minute, something's wrong. There's way too much prolactin. We got to step on the brake harder. So let's make more dopamine. So in some regards, that sort of makes sense. So that's telling us the hypothalamus is doing what it's supposed to be doing. And so there are sort of mixed things going on here. Is this low TRH is kind of worrisome. That to me strongly implies something is wrong with the hypothalamus. The dopamine being high now, is that something that the hypothalamus is reacting to? Or is there something really wrong with the hypothalamus directly? Is the hypothalamus just producing a lot of dopamine? But if that's true and the pituitary gland is intact, what would happen to the pituitary if you give it a lot of dopamine?
Decrease prolactin.
Increase of prolactin?
Decrease.
You would think it decreased prolactin. So actually there are two things affecting the lactotropes here, right? We have the effect of dopamine, which is telling it to turn on. And then we have something else. I'm sorry. High dopamine, it should be telling. Okay, now I'm getting myself confused. I'm going to try and step back. The high TRH, if TRH is high, that should be telling us to make more prolactin, right? But the high prolactin should be telling us to make more dopamine. So there's like two things going on here that are conflicted. It's like having two kids in the car, and one kid says drive faster, the other says drive slower. Very confusing. So anyhow, the answer I came up with, I think there's something wrong with both the pituitary gland and something wrong with the hypothalamus. I don't think that's probably the best answer, and I'm not really sure. This requires more work to sort that out. But I was just hoping to use this more as an example of trying to reason from what we know so far and how we can kind of reason around this. I think I failed miserably. So, okay. So we've done this for an hour and 4 minutes. That's about all I had planned to do for this CIS. Hopefully we had a chance to kind of, go over some more questions. And again, a lot of these can be helpful in terms of what to expect on the exam coming up in a week. Any other questions or comments? I think some of you, I think some of you have another test this afternoon. Is that correct? Or do all of you have a test?
All of us.
All of us.
All of you have tests. Okay. So then it's even better that we finish early and you can go do what you have to do. So again, if you have questions, afterthoughts, whatever, please email me. Otherwise, again, work hard this weekend. Don't get behind, get ahead of it all possible. And we'll see you on Monday. Monday, again, is a killer TBL because I've got material and it's a fairly long pre-read, and then Dr. K's coming in and he has a very detailed pre-read as well. But we feel strongly about Dr. K's material because if you take the national boards, there will be questions that come directly from Dr. K's talk. So it'll be worth your while to spend time going through that. Good. So I'll let you go. Good luck on your test this afternoon.
Thank you.
Thank you.
Thank you.
Dr. Honda, could you go back one slide? Is that possible?
No, I think I'm stopping here. So what was your question?
I just wanted to see the previous slide because I thought I read something that apparently I read wrong.
Well, probably question 11. At this point, it was there to torture you, and I've done that, and I think it's low yield. I don't think there's.
I just wanted to see if my brain was
You're not
broken.
going to get that much more from this because it's such a confusing topic. So